Welcome back to the CCIT orientation. This section, we're going to be going over the basics. So we've already discussed the importance of certification and how to obtain your certification. We discussed the codes of ethics for both NADAC and GACA. We discussed the 8 counselor skill groups, how to take notes, and the levels of care. So now we're going to move on to some basic counselor skills that every counselor should possess. But first, let's talk about a few facts about addiction itself. The first of which is going to be the biology of drug addiction. So people with addiction, they lose control over their actions. They crave and seek out drugs. They seek out alcohol or other substances, and they don't care about the cost. Even at the risk of damaging their friendships and hurting their family members or losing their jobs. So what is it about addiction that makes people behave in such a destructive way? And why is it so hard to quit? Well, scientists are working to learn more about the biology of addiction, and they've shown that addiction is a long-lasting and a complex brain disease, and that current treatments can help people to control their addictions. But even for those who have successfully quit, there's always a risk of that addiction returning, and that's what we call a relapse. The biological basis of addiction is going to help to explain why people need much more than just good intentions or willpower to break their addictions. So, a common misperception is that addiction is a choice or a moral problem, and all you have to do is stop. But nothing can be further from the truth. So Dr. George Koob, which is the director of the NIH's National Institute on Alcohol Abuse and Alcoholism, says the brain actually changes with addiction, and it takes a good deal of work to get it back to its normal state. And the more drugs or alcohol that you've taken, the more disruptive it is going to be to that brain. So researchers have found that a lot of addiction's power is going to lie in its ability to hijack and even destroy key brain regions that are meant to help us survive. And a healthy brain is going to reward healthy behaviors like exercising or eating, bonding with a loved one, and so on. So it does this by switching on brain circuits that make you feel wonderful, which is going to motivate you to repeat those behaviors. And then in contrast, when you're in danger, that healthy brain is going to push your body to react quickly with fear or alarm so that you'll get out of harm's way. And if you're tempted by something questionable, like maybe eating an ice cream before dinner or buying things that you can't afford, the front region of your brain can help you decide if the consequence is going to be worth the action. But when you're becoming addicted to a substance, that normal hardwiring of the helpful brain processes, they can start to work against you. So drugs or alcohol can hijack that pleasure and reward circuit in your brain, and it's going to hook you into wanting more and more. So addiction can also send your emotional danger sensing circuits into, I guess, like an overdrive. And it's going to make you feel anxious and stressed when you're not using the drug or the alcohol. So at this stage, people who often use alcohol or drugs to keep from feeling bad, they're going to start using it just for that reason instead of just the pleasurable effects. So to add to that, repeated use of drugs can damage the essential decision-making center at the front of the brain. So this is the prefrontal cortex. It's the region that helps you to recognize the harms of using addictive substances. So brain imaging studies of people addicted to drugs or alcohol have showed decreased activity in this prefrontal cortex. And when the frontal cortex isn't working properly, people can't make the decision to stop. So even if they realize that the price of taking the drug might be extremely high, they might lose custody of their children or end up in jail. But nonetheless, they take it. And scientists don't yet understand why some people become addicted and why other people don't. But we do know that addiction tends to run in families, and certain types of genes have been linked to different forms of addiction. There's no one specific gene, but certain types of genes have been linked to it. And not all members of an affected family are necessarily prone to addiction. So, as with heart disease or diabetes, there's no one gene that makes you vulnerable. And then there's other factors that can also raise your chances of addiction, like growing up with an alcoholic, being abused as a child, maybe being exposed to some extraordinary stress. All of these are social factors that are going to contribute to the risk for alcohol addiction or drug abuse. And with drugs or underage drinking, of course, the earlier that you start, the higher the likelihood is of you having uh, an alcohol use disorder, or some sort of addiction later on in life. And then, of course, teens are especially vulnerable to the possible addiction because their brains aren't yet fully developed, particularly that frontal region. And that's going to help with the impulse control and assessing risk and so on. And the pleasure circuits in the adolescent brain is going to operate in overdrive, and it's going to make that drug or alcohol use even more rewarding and enticing. But there's still a lot to learn. We do know that prevention is critical to reducing the harms of addiction. And childhood and adolescence are times when parents can get involved and teach their kids about a healthy lifestyle and activities that can protect against the use of drugs. Physical activity is going to be important, as well as getting engaged in work, science projects, art, social networks that don't promote the use of drugs. So, to treat addiction, scientists have identified several medications and behavioral therapies, especially when used in combination, that can help people to stop using specific substances and prevent relapse. Unfortunately, no medications are yet available to treat addiction to stimulants like cocaine or methamphetamine, but behavioral therapy can help. So Dr. Koob, he adds that treatment depends to a large extent on the severity of the addiction and the individual person. Some people can stop smoking a cigarette and alcohol use disorders on their own. More severe cases might require months or even years of treatment and follow up with real efforts by that individual and usually complete abstinence from the substance afterward. And then, of course, researchers are also evaluating experimental therapies that might enhance the effectiveness of established treatments. Mindful meditation, magnetic stimulation of the brain, those are being assessed for their ability to strengthen brain circuits that have been previously harmed by addiction. And scientists are also examining the potential of vaccines against nicotine or cocaine and other drugs, which might even prevent the drug from entering the brain in the first place. Addiction really is a devastating disease, and it has a relatively high death rate and some serious social consequences. Scientists are exploring multiple strategies so individuals will eventually have more treatment options, which is going to increase their chances of success to help them stop taking the drug. And in the past, we were under the moral model of addiction. This model held that if you were addicted, it was a moral failing on your part. And all you had to do was just be a better person, go to church, make better moral decisions, and then you can stop using. But now we operate under the medical model, and this model holds that addiction is a disease. And these biological models of addiction are going to emphasize the importance of genetics and the biological forces of nature. These theories suggest that brain chemistry, brain structure, and genetic abnormalities are going to cause human behavior. A lot of these models haven't been tested or applied to every specific type of addiction. Nevertheless, scientists and practitioners assume that it's reasonable to apply these models to these other addictions. And then, as research in this area continues, we might eventually learn that some models are more applicable to specific addictions. But according to this biological model, every person's unique physiology and genetics cause addiction. So people differ in the degree to which they like or dislike a particular addictive substance or activity. And some people might enjoy a substance or an activity so much that it's just going to become very tempting, and it's very difficult to resist. So another person would not experience this difficulty because they don't experience that similar enjoyment. And then similarly, the ability to temper those impulsive desires with a rational thought is a brain function that is going to vary among different people. So some people might have a deficiency in their capacity to resist certain types of impulses. And then, these folks are going to be a greater risk for developing an addiction because of that genetic vulnerability. Recovery is going to consist of recognizing and understanding one's genetic vulnerability. And once this vulnerability is identified, it's going to become necessary to abstain or at least moderate the use from addictive substances and the activities that surround them. And then treatment is going to provide education that's going to help people to understand and accept their genetic predisposition. There is a heightened emphasis on the importance of abstinence. So some questions that you can ask your client for personal reflection from a biological theory is, would it be valuable to understand your family and genetic history? Would it be wise to consider your history of failed attempts at moderation? This information is going to help the client to appreciate that they might react differently than other people to addictive substances or activities. This knowledge is going to help them understand why these addictive substances or activities are so enjoyable. It's going to help explain why their cravings are so difficult to resist. So armed with this information, it's going to make it easier for the client to avoid the substance. And then even though they like these things, the client needs to know that the genetic makeup means that they're vulnerable to developing an addiction toward that. And then they can ask themselves, could I use this new understanding to strengthen my motivation to abstain altogether? Or could I commit to moderation at a very low level of consumption? Addiction is complex, but it is a treatable disease that affects brain function and behavior. So, drugs of abuse are going to alter the brain structure and the functioning, and it's going to result in changes that persist long after the drug use has ceased. This might explain why drug abusers are at a risk for relapse even after long periods of abstinence and despite the potentially devastating consequences. There's no single treatment that's appropriate for everybody. Treatment is going to vary depending on the type of drug and the characteristics of the patient. So, matching treatment settings, interventions, and services to an individual's particular problems and needs is going to be critical to their ultimate success in returning to a productive functioning in the family, in the workplace, in society, etc. Treatment needs to be readily available because drug addictive individuals, they may be uncertain about entering treatment or taking advantage of available services. The moment that people are ready for treatment is going to be critical. So potential patients can be lost if the treatment is not immediately available or readily accessible. So as with other chronic diseases, the earlier the treatment is offered in the disease process, the greater the likelihood of those positive outcomes. And then effective treatment attends to multiple needs of the individual, not just their drug abuse. So to be effective, that treatment has to address the individual's drug abuse and any associated medical, psychological, social, vocational, and legal problems. And it's also important that the treatment be appropriate to the individual's age, their gender, their ethnicity, and their culture. And also, remaining in treatment for an adequate period of time is going to be critical. The appropriate duration of the individual depends on the type and the degree of the patient's problems and needs. So, research has indicated that most addicted individuals need at least 3 months in treatment to significantly reduce or stop their drug use. and that the best outcomes occur with longer durations of treatment. So, recovery from drug addiction is going to be a long term process, and it's going to frequently require multiple episodes of treatment. And as with other chronic illnesses, relapses to drug abuse can occur, and it should signal a need for treatment to be reinstated or adjusted. Because individuals often leave treatment prematurely, um, these programs should start to include strategies to engage and keep these patients in treatment. And lastly, behavioral therapies, including individual uh, and family therapy, group counseling, are the most commonly used forms of drug abuse treatment. So these behavioral therapies are going to vary in their focus, and they may involve addressing a patient's motivation to change, maybe providing incentives for abstinence, building skills to resist drug use, replacing those drug using activities with constructive and rewarding activities, improving their problem solving skills, facilitating better interpersonal relationships, and then also participation in group therapy and other peer support programs during and following treatment can help them to maintain their abstinence. So, knowing their drug use is being monitored, it can be a really powerful incentive for patients, and it can help them withstand these urges to use drugs. Monitoring also provides an early indication of a return to drug use, and it's going to signal a possible need to adjust the individual's treatment plan to better meet their needs. And then typically, drug abuse treatment addresses some of the drug related behaviors that are going to put people at risk of these infectious diseases. So, targeted counseling focused on reducing the infectious disease risk can help patients further reduce or even avoid substance related or other high risk behaviors. So, counseling is going to be able to help those who are also already infected to be able to manage those illnesses. And then engaging in treatment is going to facilitate their adherence to any medical treatments that they have already. So these treatment facilities, they should provide on-site rapid HIV testing rather than just referrals to off-site testing. And research is going to show that doing so is going to increase the likelihood that these patients are going to be tested and they're going to receive their test results. We call the testing HAART, HAART. So treatment providers should also inform patients that the HAART, or the highly active antiretroviral therapy, has proven effective in combating HIV, including among the drug abusing populations. And it's going to help them with their HIV treatment if they do test positive. So, family structures in America have become more complex, growing from the traditional nuclear family to single parent families, step families, foster families, multi generational families. So, when a family member abuses substances, the effect on the family can differ according to the family structure. So, a growing body of literature suggests that the substance abuse has distinct effects on different family structures. So, for example, the parent of small children might attempt to compensate for deficiencies that their substance abusing spouse has sort of developed as a consequence of that substance abuse. And then frequently, these children may act as surrogate spouses for the parent who abuses the substance. So, for example, children might develop elaborate systems of denial to protect themselves against the reality of their parents' addiction. And because that option does not exist in a single parent household with a parent who abuses substances, children are going to be likely to behave in a manner that is not age appropriate to compensate for that parental deficiency. And then we have the aging parents of adults with substance use disorders. They might maintain inappropriately dependent relationships with their grown offspring, and they're going to be missing the necessary launching phase in that relationship, which is so vital to the maturation process of the family members that are involved in that. And the effects of the substance abuse are frequently going to extend beyond that nuclear family. So, extended family members might experience feelings of abandonment or anxiety and fear and anger and concern, embarrassment or guilt. And they might want to ignore it or cut ties with the person abusing the substances. Some family members might even feel the need for legal protection from the person who's abusing the substances. And then the effects of the family might continue for generation and generation. So these intergenerational effects of substance use can have a severe negative impact on role modeling and trust and concepts of a normative behavior, and that can damage the relationship between the generations. So, for example, a child with a parent who abuses substances might grow up to be overprotective and a controlling parent who doesn't allow their children sufficient autonomy. Neighbors and friends and coworkers might experience the effects of substance abuse because the person who abuses the substances often is unreliable. So, friends might be asked to help financially or in other ways. Coworkers might be forced to compensate for decreased productivity or carry a disproportionate share of the workload. And then as a consequence, they might resent the person who's abusing the substance. And then people who abuse substances are likely to find themselves increasingly isolated from their families. Often they might prefer associating with others who abuse the substances and then participate in some sort of form of antisocial activity. And these associates are going to support and reinforce each other's behavior. So different treatment issues are going to emerge based on the age and the role of the person who uses the substances in the family, and on whether or not small children or adolescents are present. So, in some cases, a family might present a healthy face to the community while the substance abuse issues lie just below the surface. So, in 1992, Riley described several characteristic patterns of interaction, one or more of which are likely to be present in a family that includes parents or children who abuse alcohol or illicit drugs. So, the first one is negativism. This is any communication that occurs among a family who where the member is negative. It's going to take the form of complaints, criticism, other expressions of displeasure. The overall mood of the household is decidedly downbeat and positive behavior is ignored. So, in such families, the only way to get attention or enliven the situation is to create a crisis. And this negativity might serve to reinforce the substance use. The second one is parental inconsistency. So, this rule setting is going to be erratic, enforcement is going to be inconsistent, and the family structure is just inadequate. The children are confused because they can't figure out the boundaries of right and wrong. And then, as a result of that, they're going to behave badly in the hopes of getting their parents to set some clearly defined boundaries. Without any known limits, the children can't predict the parental responses and adjust their behavior accordingly. So these inconsistencies tend to be present regardless of whether the person abusing substances is a parent or a child, and they're going to create a sense of confusion. So the key factor here is in the children. Then the third one is parental denial. So despite the obvious warning signs, the parental stance is one, what drug alcohol problem? We don't see a drug alcohol problem. Or two, after the authorities intervene, you're wrong. My child does not have a drug problem. And then we have the fourth one, which is a miscarried expression of anger. So children or parents who resent their emotionally deprived home, they are afraid to express their outrage. And they use drug abuse as one way to manage their repressed anger. And then we have self medication. So either a parent or a child will use the drugs or alcohol to cope with intolerable thoughts or feelings like severe anxiety or depression. And then we have unrealistic parental expectations. So if parental expectations are unrealistic, the children can excuse themselves from all future expectations by saying, in essence, you can't expect anything of me. I'm just a pothead or a speed freak or a junkie. And then they may work obsessively to overachieve, all the while feeling that no matter what they do, it's never good enough. Or they might make a joke and clown to deflect the pain away, and they may withdraw to sidestep the pain. If the expectations are too low, then the children are told throughout their youth that they're certainly going to fail. And they're going to tend to conform their behavior to their parents' predictions unless some meaningful adult is going to intervene with healthy, positive, and supportive messages. So, in all of these cases, what's needed is a restructuring of the entire family system, including the relationship between the parents and the relationships between the parents and the children. So, in any form of family therapy for substance abuse treatment, consideration should be given to the range of social problems that are going to be connected to substance abuse. Problems like criminal activity, joblessness, domestic violence, child abuse, or neglect, they may also present in families that are experiencing substance abuse. So, to address these issues, treatment providers need to collaborate with professionals in other fields. So, this is known as concurrent treatment. And whenever family therapy and substance abuse treatment take place concurrently, communication between the clinicians is going to be vital. And then, in addition to family therapy and substance abuse treatment, multifamily group therapy, and then individual therapy and psychological consultation might also be necessary. With these different approaches, coordination, communication, collaboration, and exchange of the necessary releases of confidential information are going to be required. And with concurrent treatment, it's important that goal diffusion does not occur. Empowering the family is a benefit of family therapy that should not be sacrificed. So, if family therapy and substance abuse treatment approaches are going to conflict, these issues should be addressed directly. Case conferencing often is an efficient way to deal constructively with multiple concerns, and it provides a forum to determine these mutually agreeable priorities and treatment plan coordination. Um, Moving on, we have dysfunctional family roles. So, a dysfunctional family is one in which bad behavior, uh, conflicts, and frequently there's abuse and neglect by one or both of the parents, and it's going to happen regularly. So these children of the dysfunctional families most often grow up in households thinking that this is how every family behind the doors acts in their family home. So dysfunctional families are most frequently um, because of the parent, because one of the parents is an addict, and in some way, maybe they're undiagnosed or untreated mental health condition somewhere. And then typically the other parent is going to be codependent. We call that other parent the enabler, but the enabler is most likely codependent. So these dysfunctional families, the parents are usually imitating their own dysfunctional parents. And this is because as children, we all imitate our parents to some degree. So it's likely that these dysfunctional behaviors have kind of been in that family blueprint or the way the family has been and its rules for generations. It's handed down from generation to generation. And these new generations aren't going to question it because as children, we have nothing else to measure it against until we start going out into the community and saying, oh, well, maybe they don't do it like that when you're having dinner out at a friend's house or something. So, particularly in the first 10 years of life, we're being molded. We're learning how to respond and behave and finding out what's morally right and wrong. And this means that growing up in a dysfunctional family can really negatively impact us for the rest of our lives. So, it's going to be normal in a dysfunctional family for there to be a relentless amount of criticism, little to no empathy, and there's often neglect and abuse. Because of this, it's going to leave all of the family members with no understanding of what a healthy boundary is for themselves, and consequently, how to insist on and enforce one. There's either conflict issues. There's going to be conflict issues between different family members. No discussion, as it might lead to conflict, and there's almost always continual conflict in these families. There's going to be inequality. Treatment of one or more family members is not steady or fair. And this can be due to things like gender, age, birth order, intelligence, abilities, or their role in the family. And it means that family rules and norms are inconsistent and confusing. There's going to be healthy communication difficulties here. This is not only between themselves, but also outside the family. So, dysfunctional families are going to be extremely strict about the rule that when it comes to any information about them, nobody must ever know. What's said in this house stays in this house type of situation. There's also going to be a lot of denial going on. This means living with the belief that their unhealthy family situation is normal and or even useful to them. So this denial is usually not overtly conscious. It's complex and it has a lot to do with the fact that there's no concept of what healthy family is like. The family blueprint also hands down these moral obligations that, if not followed, are going to leave them feeling guilty and even full of shame as going back generations, quote unquote, this is the way our family's always done it. So, what are the dysfunctional family roles? Well, as you can see on this picture, they're laid out for you, but These are also known as family survival roles, which to a great extent just explains why these roles develop. But it's important to realize that dysfunctional family roles can be flexible, and this means that one family member will mostly be given or adopt one role, but they can also shift to aspects of or fully at a certain time another role if changes occur within the family. Like for myself, I played namely the hero, but at times I was the lost child or played parts of the lost child. So, first, let's talk about the addict. This is sometimes known as the identified patient. And this person may be addicted to some sort of alcohol or drugs or a behavioral addiction like work or sex or food or gambling, as well as things that change the way that they feel, like power and rage. So, whether they are in active addiction or getting treatment, they're very often going to be the family's focus. So, within the addict role can also be the roles of being the victim, the rebel, and an offender. And then we have the codependent or the co addict, which we call the enabler, the chief enabler. Most people think that a dysfunctional family must always be just about to break apart and that one of the parents is going to leave the other person. But this is frequently, in fact, not the case at all because the parents have quote unquote found each other. So the codependent parent gets the external validation that they need from the other parent. They feel needed because they feel that the addict cannot survive life without them. It's about desperately seeking that love and approval. And this is most usually because their basic needs were unmet when they were a child. So the addiction or addictions are tolerated and often ignored, and excuses are readily made for the addict because the codependent or the enabler is addicted to the relationship. And this is the reason that in some cases the addict will neglect or abuse their children, and yet the codependent will not stop it or even say anything. And the codependent may also be addicted to emotions like anxiety or sadness that serve as distractions from that painful emptiness that they feel deep down. And this role has many aspects of the caretaker role. Um, Although the caretaker role is often adopted by or assigned to one of the family's children as well. So this caretaker role, we can call it the caretaker, the golden child, the hero, the saint, the super kid. Most of the time it's going to be referred to as the family hero. This is the child who can do no wrong because they're so perfect. It lets the family just believe that there's nothing wrong because they've obviously done something right, just like everyone is always telling them. But the hero is going to have this intense pressure to continue with their achievements or risk exposing what the real dysfunction of their family is. So they're most likely only going to get attention when they're achieving something. So they're often going to become perfectionists and they're set up for a very stressful life. They only feel as if they are somebody if they're achieving something. So this role is frequently seen in a family with one or both parents suffering from a narcissistic personality disorder. A narcissist loves the image of themselves, but not their true self, because inside they're always going to feel unlovable. So they're continually seeking love and approval through their image. And then we have the clown or the mascot. So, as a rule, the atmosphere in a dysfunctional family is pretty tense. So, the clown is going to step in as the role of the mood lightener. They're going to avoid something boiling over again. So, as with the caretaker, they're going to be on high alert at all times. They might be perpetually ready with some humor or clowning around to act as a distraction from any potential issues. And each time this works, the pressure is pushed up for them to act in a similar way the next time. This pressure means that they're most likely going to be full of constant anxiety inside. And then in adulthood, they're going to continue to use that humor and amusing behavior to deal with any potential conflict when often an issue really needs to be discussed or faced. They may well end up in a dysfunctional relationship in which they can use their clown skills. And then we have the lost child. So wherever there's a hero, there's a lost child. They attempt to stay out of the dysfunctional picture as much as possible. They stay quiet on their own. They fend for themselves as much as possible. Their needs are going unmet anyway. Consequently, this child is going to withdraw and feel alone, and they're going to desperately yearn for love and approval and attention, but they're unlikely to have any positive social skills or any healthy self-esteem. And this can continue into their adulthood. And so they're going to struggle to have any real meaningful relationships as they get older. And then you have the scapegoat, which is clearly what it is. This is the troublemaker, the black sheep of the family. And someone has to be blamed for the family's continual problems. The scapegoat and the golden child are often put against each other, and that's going to serve to strengthen their dysfunctional family roles. In actual fact, the scapegoat is frequently the only emotionally stable one in the family. And they're the ones that speak the truth about the family's dysfunction. But because they have broken the rule that nobody must know, the family's going to make them pay by labeling them as the problem. They cause all of the family's troubles. They may only get any attention when they do something that causes a problem. So they cause problems like misbehaving at school or getting in trouble with the police. The scapegoat is usually assigned their role at a very young age, and then they are from then on in a clear no-win situation because everything they do is seen as bad or wrong. It can leave them feeling guilt-ridden and full of shame, and this can have obvious negative impacts when they're adults. So in recovery, it's going to be essential to know what dysfunctional family role or roles that someone might have had or have created in their family that they have created. So it's going to be helpful to understand why they are as they are in adulthood. So now let's talk about what is counseling. Counseling is a collaborative effort between the counselor and the client. Professional counselors are going to help clients to identify their goals and potential solutions to their problems, which cause emotional turmoil. They're going to seek to improve communication and coping skills and strengthen self esteem and promote behavior change and their optimal health. The therapeutic relationship is the connection and the relationship that's developed between the therapist and the client over time. So, without this therapeutic relationship, there can be no effective or meaningful therapy. This applies to all forms of counseling and psychotherapy, and regardless of the theoretical orientation of the counselor, the relationship developed between the two of you is going to be considered of high importance. A strong bond is crucial to the success of counseling and psychotherapy, and it can be especially valuable to clients who may have struggled forming relationships in their past and those who experience traumatic events in their early years, which is going to lead them to find it difficult to form relationships in adulthood. So, therapy is going to allow clients to a chance to kind of explore their relational attachments, their bonds and experiences through their relationship with their counselor, which is why this relationship is so important. A collaborative therapeutic environment and the relationship is going to be that place to explore their problems and have these candid conversations, brainstorm some potential solutions, and possibly reflect on any alternatives that are out there. Collaboration is about negotiating the goals for counseling and deciding on a pathway on how to reach them. This also means voicing different opinions, concerns, curiosity, questions, or ideas about the direction of counseling. What has been helpful and what is missing from the counseling and or what's not working. So in other words, collaboration is not intended to be a perfect alignment. Rather, it's just going to signify a partnership that's experienced, that is open and respectful and energized and personal. And then counselors today are working with increasingly diverse populations that have diverse sets of needs. So honing a solid set of these essential skills is going to make for an effective, successful mental health practitioner. So these skills can include a general interest in others, self-reflection, the ability to listen on multiple levels, accessibility and authenticity, flexibility, and a sense of humor. These are just a few of the skills that the counselors need to hone in order to help their clients. Counselors are going to provide positive reinforcement to their clients too. Positive reinforcement in therapy helps clients to understand the connection between a situation and their behavior and how that situation is going to respond to their behavior. So it can start by simply offering a person a reward if they complete a task, with the idea of eventually helping them learn vital life skills to use when they're out of therapy. So, in general psychology, positive reinforcement is that fundamental concept to replace bad behaviors with desirable ones, and it's going to help to strengthen the development of those desirable behaviors. It works by adding a stimulus after a behavior to make it more likely that the person is going to do the behavior again in the future. The stimulus is usually rewarding or reinforcing in nature. Adding it immediately after the behavior or drawing a distinct connection between the behavior and the stimulus is going to strengthen that desirable response or behavior. So, when dealing with positive reinforcement in psychology and therapy, positive doesn't necessarily mean something good. Instead, positive should be thought of in a mathematical term, like adding something. Positive reinforcement is ultimately the addition of something good as a result of the person uh, engaging in that desired behavior. So, counselors can provide emotional support. People show emotional support for others when they offer genuine encouragement or reassurance and compassion. So, this might include things like verbal expressions of sympathy or physical gestures of affection, like a pat on the back. And then lastly, counselors can keep a formal record. So remember, if you don't write it down, it didn't happen. Um, Generally, the ethical principles that we adhere to are going to require the maintenance of appropriate records or psychological services. So the nature and the extent of the record is going to vary depending on the purpose and the setting and the context of the psychological service provided. So, counselors should be familiar with legal and ethical requirements for record keeping in their specific professional context and their jurisdiction. These guidelines are not intended to describe the requirements fully or to provide legal advice. Records benefit both the client and the counselor through documentation of treatment plans, services provided, and client progress. So, record keeping documents the counselor's planning and implementation of the appropriate course of services, allowing the psychologist to monitor their work. These records are going to be especially important when there are significant periods of time between contacts or when the client gets services from another professional. And then appropriate records can also help protect both the client and the counselor in the event of any legal or ethical proceedings. Adequate records are going to be generally a requirement for third party reimbursement for any psychological services rendered. And then the process of keeping records is going to involve consideration of legal requirements, ethical standards, and any external constraints, as well as the demands of any particular professional context. So, in some situations, one set of considerations may suggest a different course of action than another, and it's really up to the counselor to balance those appropriately. A substance abuse treatment plan is one of the foundational parts of addiction treatment. It's so important that most treatment centers won't let you go a day in treatment without one. And there's no one size fits all approach to treatment that works for everybody. So, treatment plans are one of the ways that drug rehab is tailored to address the needs of the client. So, through the treatment process, the client's goals and the treatment plan are used to treat the client in a personalized and individual way. So let's talk about this. Um, Goals and objectives as part of the treatment plan. It's easy to consider these two words as synonyms, but in the context of addiction treatment, they each refer to different things. So you'll find both both of them inside of the treatment plan for addressing a substance use disorder. And when you start to form your treatment plan, you're going to start with this goal. A substance abuse treatment plan is one of the foundational parts of addiction treatment. It's so important that most treatment centers won't let you go a day in treatment without one. And there's no one size fits all approach to treatment that works for everybody. So, treatment plans are one of the ways that drug rehab is tailored to address the client's needs. And through this treatment process, the goals and the treatment plan used to treat the client is going to be personalized to the client's individual needs. Um, a substance abuse treatment plan is one of those foundational parts of addiction treatment, and it's so important um, for that reason. So, the client might make their treatment plan on the first day, and this is going to happen after intake and the assessment process. The plan is going to change over time. So, for instance, in the early stages of rehab, the client might go through a process of medical assessment, stabilization, and detox. And then after that, the plan may change to focus on deeper issues of addiction like mental health and social issues and other problems. So the treatment plan is going to include three major components. It's going to be the goals, objectives, and the interventions. After the client makes their treatment plan, you will continue to meet with the client to reassess it and make changes as needed. This reassessment should happen at least weekly. So, what are goals and objectives? It's easy to consider these two words as synonyms, but in the context of addiction treatment, they each refer to different things. So, you'll find both of these in a treatment plan for addressing a substance use disorder. And when you guys start to form your treatment plan, you're going to start with a goal. So, goals are big, overarching objects of the client's effort in their treatment plan. They're usually simple and easy to define, but they might be difficult to grasp and vague as to how the client's going to achieve them. It's easier to understand what a goal is with an example. So, the most common goal in addiction treatment is to achieve abstinence from drug and alcohol use. This is one of the most important aims of addiction treatment. But how the client is going to achieve it and what specific steps they're going to take to get there is the question. So, if the treatment plan is a journey, the goal is a tall mountain in the distance that you're headed toward. The client can see it, but they can't see all the roads that are going to take them there. So, still, defining a goal is essential in pointing the client in the right direction and informing the rest of the treatment plan. An objective is more specific, and there are usually multiple objectives that are going to help the client to work toward that single goal. An objective is a clear, specific thing, so it's easy to know what it takes to complete it. So, for instance, an objective might be to complete a biopsychosocial assessment with the counselor. Another example might be to respond to someone else 3 times in your next group therapy session. An objective is the road that leads you to the mountain. And so, as the client attempts to complete the goals, you're going to help them and assess with them each week. So, ideally, each completed objective is a step toward reaching that goal. And then finally, the third element of a treatment plan is the intervention. So the intervention is something that you, the counselor or medical professional, does to help the client process or work through their objectives. Interventions might be a key component in helping that client advance in their treatment plan. They provide accountability, challenges, and direction during the treatment. Addiction recovery programs are going to aim to help you and the client craft the goals that are relevant and meaningful to the client. So, to do this, you need to encourage the client to consider their personal expectations against the expectations of the people that are around them and help them to create a plan on how they can achieve a healthier way of life. We also want to discuss the treatment modality with the client. There are several modalities or methods of treatment. We have individual therapy, group therapy, couples therapy, family therapy. Those are the most common types. In an individual therapy session, a client works one-on-one with a trained therapist or counselor. In group therapy, usually 5 to 10 people are going to meet with that trained group counselor to discuss the common issue like divorce, or grief, or eating disorders, substance abuse, or anger management. Couples therapy is going to involve two people in an intimate relationship who are having difficulties and they're trying to resolve them. The couple may be dating or partnered, engaged, or married. The counselor is going to help them resolve their problems as a way uh, to implement strategies that are going to lead to that healthier and happier relationship. And then family therapy is a special form of group therapy, and this therapy is made up of one or more families. So the goal of this approach is to kind of enhance the growth of each individual family member and the family as a whole. But in therapy or counseling, a treatment plan refers to the specific goals that you have for therapy and the interventions that you might use to help the client to reach their goals. Typically, this treatment plan is created early on in the therapeutic process, and it's going to serve as a guideline to drive the sessions in a way that fits with what the client hopes to achieve. They're usually updated on a regular basis, often every 6 months or so, to allow for changes in priority and to reflect on the progress that the client has made. A treatment plan is often discussed in that first session or very early on. A common question that you can ask a client in some variation is, what do you hope to get out of the coming of you coming to therapy? Or what might also, or some, I'm sorry, you might also ask, what are your goals for treatment? Or would you know if things have improved? Each treatment plan is going to be unique and based on that individual's symptoms and needs and goals. However, you might choose some interventions informed by your theoretical orientation. You also want to discuss a schedule with the client that works for both of you. Um, and scheduling can take up a good deal of time in an individual practice. So, fielding and responding to emails and calls from prospective clients, determining dates and hours that work for the both of you. It is part of the job and it's not a small task. So, you just want to make sure that that is what's working best for you. The efficacy of that weekly model is no longer certain. So 1 hour once a week has come to us from this trickle down psychoanalysis. And while good work can certainly be done in a weekly and higher frequency engagements within a variety of treatment frames, it's not a therapeutic given. And what's more, the idea of the weekly work will continue indefinitely is going to set up an expectation that the client needs long term help. As expectation so often leads to experience, there is now an indefinite amount of time that this person, regardless of the issue, will live as a patient. So, not everybody needs weekly therapy for 2 years. And to suggest and more to demand that this is a condition of treatment is just unconscionable. It's not just counselors. Insurance companies require a diagnosis after the first session as, of treatment as a condition of payment, and a diagnosis which goes and remains on the patient's medical record. Is this in the patient's best interest? Is it an accurate diagnosis? Can we even get an accurate diagnosis within 50 minutes? All of this is pointing to a trend to place the economic interests and functional concerns of the industry above the therapeutic needs and the rights of the people our industry is ethically bound to serve. Um, we also need to make sure that we are informing the client that there may be potential involvement of other people, like people on the treatment team, other counselors, supervisors, your clinical supervisor, or maybe a probation officer or an attorney. And we also need to discuss termination right from the very beginning. So the end of therapy can be difficult. And when you have that long and trusting relationship, the end is going to be a major milestone. But, we know that a client can terminate therapy whenever they want to for any reason or for no reason at all. But knowing when to terminate therapy is an important skill that can protect both you and the client. So we want to make sure that we're discussing it from day one. We want to prepare the client to terminate treatment. Um, it can, termination can make both the counselor and the client feel insecure, um, wondering what they did wrong or leaving, maybe somebody's at fault, or maybe there's some fear going on there, or maybe they don't have enough support. So just remembering that the purpose of therapy is supporting the client. Um, don't get defensive about the reason for termination, especially if the client's unhappy. Don't argue with the client or use the discussion to ease your own hurt feelings. Be clear, direct, and compassionate no matter why the client is leaving. Never blame the client, even if you have to terminate therapy because the client is difficult or you're not a good fit. Make sure you're willing to answer any questions about therapy termination, such as where the client can seek additional help if necessary. And don't abandon a client without warning. The state licensing board or certification board may prohibit terminating therapy with no notice, without a final session, or without referring the client to another counselor. So, a clear understanding of your ethical duties and your state board rules can help you better serve your client and avoid any disciplinary procedures. And if at all possible, refer the client to a highly qualified counselor or therapist who specializes in their particular issues. This is particularly important if you terminate the relationship because of fit issues or because you are unqualified to treat the client. Termination can offer opportunities for therapeutic intervention, and clients who struggle with grief, attachment, or loss, they may need some help in managing that termination. Termination may even be a bridge to resolving some of these issues. All right, so we are out of time for this particular session. Um, Please make sure that you complete the quiz and answer any of the questions that I have posed in here, or if you have any questions, feel free to put them in the chat box in the lesson, and your certificate will be emailed to you upon completion of the quiz, of passing grade on the quiz. And make sure you fill out this survey for this course. Thanks for joining us.